Hello, this is Angelica. I will be presenting along with Manny Albano, Leslie Simpson Crawford, and Nicole Ware on health information technology and patient safety. Thank you for your time. Health information technology originated in April 2004 when President Bush signed Executive Order 13335. This order recognized the need for an infrastructure to improve the quality of healthcare. It promoted the development of a nationwide interoperable health information technology infrastructure that would create a more effective marketplace. As health professionals, we use HIT to gather information on healthcare costs to improve the quality of care and outcomes. HIT was established through the Office of the National Coordinator for Health Information Technology, known as ONC. ONC has the responsibility to ensure that every American has access to his or her electronic health information and to establish connection of HIT. Health information technology improves interdisciplinary and intradisciplinary teams. Care coordination is improved through health information exchange. Implementation of HIT helps coordinate patients' care with other providers through the secure and private sharing of clinical information. The Patient Protection and Affordable Care Act emphasizes the use of health information technology. It measures and enhances the quality of care given to patients. It establishes new methods and models to deliver care and improves health outcomes while reducing expenditures.
This is Manny Alvano. I will be discussing the impact of health information technology on patient safety, as well as the consumer and healthcare professionals' perspective on this topic. David Brailer, former National Health Information Technology Coordinator for the United States, defines health information technology as the application of information processing involving computer hardware and software that deals with the storage, retrieval, sharing, and use of health information, data, and knowledge for communication and decision making. The Institute of Medicine defines patient safety as the prevention of harm to patients. Great emphasis is placed on error identification and prevention, learning from errors, and a culture of safety involving healthcare professionals, organizations, and patients. In 1999, the Institute of Medicine estimated that up to 98,000 people die per year as a result of medical errors. In the journal Patient Safety, John James estimated that the deaths from medical errors are actually between 210,000 and 400,000 per year, or 1,000 per day. Additionally, there are approximately 10,000 serious complications from medical errors per day. Ken Kiser, former CEO of the National Quality Forum, coined the term never events. They are the medical errors that occur in hospitals that you would never want to happen to you or your loved ones. The Joint Commission calls these medical errors sentinel events. They include wrong site surgery, wrong patient surgery, retention of a foreign object, medication errors, hospital-acquired infections, failure to follow up or communicate test results, unsafe administration of blood products, and death resulting from introduction of a metal object in the MRI area. Health information technology has made a significant impact on patient safety. Communication amongst disciplines, providers, and nurses is key, which HIT provides. Computerized physician order entry eliminates illegible and duplicate orders. One study reported a 12.5 decrease in errors. Electronic health records communicate the plan of care. King et al. Reported 78% of physicians said that EHR enhanced patient care, and 62% said they were alerted to results of critical tests. Barcode medication administration enhances the 5 rights of medication administration, with a 41% decrease in med errors, according to one study. Smart IV pumps prevent errors in dosing, particularly with high-risk, high-alert drugs. EMARs are accessible to the entire team. E-scribing allows immediate prescriptions to go to the patient's pharmacy and home delivery. Decision support systems promote evidence-based practice and best practice. Telehealth services are far-reaching and decrease disparity. A story on ABC7 News on August 5th reported that psychiatrists who utilized telepsychiatry noted that missed appointments went from 41% to 18%. This ultimately promotes wellness and safety for the patient. Health information technology enhances patient care. Errors are noted to occur when patients transfer from unit to unit, providers and caregivers. HIT improves coordination of services between providers, nursing units, disciplines, and caregivers. It provides remote access 24 hours a day. 81% of physicians in one study reported positive feedback. It empowers clinicians by supporting prevention, detection, and management of diseases. It can eliminate care disparities by improving access to care. It includes home-based monitoring systems which promote safety, such as fall detection, sleep, med adherence, and vital signs. And patient portals encourage patient engagement in their care. Patients, their families, and the public as a whole have become more aware of medical errors and the positive impact HIT can have on patient safety. Media and the internet have been the biggest source of information to the public. One of the well-publicized cases was the heparin overdose of Dennis Quaid's twin babies in 2008. He returned to Cedars-Sinai in 2009 to meet with Linda Burns Bolton, Chief Nursing Officer and Vice President of Patient Care Services. She explained that the hospital had invested over $100 million on HIT that would have prevented the error made with his babies. She demonstrated barcode med administration. This was aired on 60 Minutes and the Oprah Winfrey Show. Dennis Quaid is now an advocate for HIT and patient safety. Patient advocacy groups such as Patients for Patient Safety, the Leapfrog Group, and the Safe Patient Project aim to make the public aware of medical errors and how hospitals can make patient care safer. Healthcare organizations and healthcare professionals want safe patient care. Most acknowledge the importance of HIT for patient safety. The longer the experience with HIT, the greater the perceived benefits. Barriers include cost and initial resistance for implementation. Skeptics question the benefits because sentinel events continue to increase. According to Espinoza and Bay, the EHR has not decreased sentinel events. Once an event occurs, however, EHRs reduce death by 34%, readmission by 39%, and cost by 16%. Medical errors are now considered the third leading cause of death in the United States, behind cardiovascular disease and cancer. Continued improvements and the future at UCLA Health. UCLA has recently upgraded to Epic 2014. Optimization continues to occur, which includes improvements in assessment tools, workflows, and treatment plans. Barriers to barcode med administration were identified, since workstation on wheels are not feasible in all departments, particularly the emergency department and psychiatry. Pilot use of cell phones, which are called Rover, for portable scanning of patient identification and medication administration will begin on August 10th. E-consults and smart referrals have been implemented. These programs provide primary care providers with point-of-care decision support on referral appropriateness.
Some common misconceptions about health information technology is that the transparency creates a problem, that health information technology tools will be problem-free, and that there is no way to ever have a centralized location to access information. There has to be a balance between confidentiality and transparency. The segregation of information causes gaps in care, redundancy in services, and vagueness in accountability. In reality, without transparency, care coordination suffers and there is no cost competition, which in turn promotes unfair pricing, and as a result, patients and patient care suffers. Transparency is a good thing. In truth, a great deal of what is found on the internet is not valid or scientific. Most of it is false, but we cannot expect our patients to stop consulting the source, nor should we want them to. We need to educate our patients on how to find valid, evidence-based information and then have a conversation with their healthcare provider about what they have discovered, making it personal. Less than 12% of all people are deemed to be health literate, so it's unfair to assume that someone can access their records from home. Fair assessment of that ability needs to be done before assumptions are made. Healthcare organizations are just beginning to be able to communicate and join our health information exchanges. The information may not be available to providers outside of one's own healthcare system, such as Epic or Meditate, because they don't talk, usually. States are developing health information exchanges with grant money. States like North Carolina and Indiana have received grants in the millions of dollars from the Office of National Coordinator for Health Information. This is to encourage breakthrough innovations for health information exchanges in those states. These exchanges are expected to facilitate interoperability and information exchange. Requirements of these exchanges will be to create and implement up-to-date privacy and security requirements in line with HIPAA and other regulations, coordinated with Medicaid and state public health programs, monitor and track meaningful use, comply with national standards, and support this transition. The dollars are used for that. The future for health information technology is bright. There is a 3-year agenda now through 2017. The function is that all health information technology systems be able to send, receive, find, and use common clinical data set to improve healthcare and health quality. There's a population focus. It's really based on hospitals, physician offices, long-term care facilities, and behavioral health providers. And the data set includes allergies, medication lists, and diagnoses. The longer term goal for the future is a 6-year agenda and a 10-year agenda. In the 6-year agenda, the focus is to increase the number of interoperable health IT and users to improve healthcare and decrease costs. In the 10-year agenda, the function is to achieve a nationwide learning health system. The expansion of the program to eventually include individuals and providers from all disciplines. It would include those in non-healthcare related settings, such as long-term service support and public health. How can we apply this information technology to our organization? What have we learned as far as how it improves healthcare and patient care? Many nursing point of care environments can utilize technology interventions that are customized for each patient. Technology that recognizes abnormal values, trending enzymes, and irregular vital signs can be very useful. Technology allows all of the patient's information to be centrally located and easily referenced. I see this as being a great improvement to the delivery of healthcare and patient care. So what are the incentives and disincentives? Care will be based on the most recent evidence. We know evidence-based care is safest for the patient. Arguably, there is reduced time computer charting versus paper charting. And absent of the workarounds we find that really make patients unsafe, this system and technology really works to decrease errors. Disincentives: minimal rigorous research has been conducted, so we don't know the long-term ramifications because we just haven't been doing it long enough. There is data overload. Therefore, there is a lack of clarity on what we should be collecting and how long we should keep it and how it should be used. Lastly, the ambiguity. Without the ability to chart in free text, many of the nuances may be lost to standardized scale, therefore influencing patient care as well.
Health information technology, HIT, is central to current clinical practice. This trend began in 2009 with the HITECH Act, which subsidized adoption. The Affordable Care Act then established HIT standards for all practitioners and organizations. As of March 2015, with 95% of eligible professionals in hospitals with EMR systems, Phase 1 is deemed a success. Core to the current adoption trend of EMRs is the Meaningful Use Program, where the government reimburses HIT costs for organizations that work with Medicare and Medicaid. This has led to a significant increase in adoption. Clinical Decision Support Systems, CDSs, are also in place to assist care providers with many tools that cumulatively decrease medication errors and increase diagnosis accuracy. Computerized Physician Order Entry, CPOE, is central to this, which auto-checks for errors or other potential problems when ordering medications, labs, or radiology. Finally, the National Coordinator for Health Information Technology has spearheaded the Standards and Interoperability Framework project. This framework establishes standards for vendors of EHR systems, which allow record access between the vendors in a variety of transport and quality standards. HIT, while not perfect, has realized real advantages. Among these are timely and broad access to records. Oregon State has established an access hub that links EHRs to hospitals in the Portland area. While such broad access is not yet widespread, support for interconnectivity efforts is. The U.S. government recently accepted a bid for a military-wide system for managing medical records to be piloted in Washington state. Closely tied to EHRs is patient safety. Medical-related errors account for a large number of deaths yearly in the United States. HIT systems reduce these errors primarily through medication error reduction at the bedside and pharmacy. These systems accomplish this with several tools. For example, redundant alerts and patient verification, often using patient photo identification. HIT systems also simplify and expand the ability to code records, ensuring accuracy and timeliness of claims. EMRs also focus healthcare more on the patient by reducing the amount of time spent accessing information, increasing time at the bedside. Finally, HIT systems introduce big data to the medical field, allowing public health agencies to realize health trends in the population. HIT is not without unintended consequences. As healthcare professionals, our core responsibility is to do no harm. These systems introduce a new path for unintentional harm. E-itronogenesis, errors caused either by or through the HIT system. E-itronogenesis is often caused by human error, but can be vendor or hardware related. Access is a huge advantage, but can be hard to limit effectively. Security, both in person and in data transport, has been less than perfect, as shown by the data breach at Anthem, where more than 80 million people had their private data stolen earlier this year. Finally, subsidies for HIT systems are sunsetting, leaving late adopters with high overhead costs for adoption. The military is paying a base implementation cost approximately at $11 billion. Alongside this are the ongoing issues of training, technical support, and policy maintenance with associated costs. HIT systems have many ethical and legal gray areas. CDS systems offer a tempting trap for many physicians, which may lead to malpractice. To avoid this trap, clinicians have to take full responsibility for diagnosis, regardless of CDS access. Malpractice suits may also be predicated on failure to use information available in HIT systems. Overly complicated or poorly designed HIT systems often bury clinical relevant information, leaving the clinician at fault. Institutionally, security of private information, both in transport and at system endpoints, creates a hazard that must be addressed. Institutions may be held liable for lack of effective implementation and are also responsible for acquiring effective and safe systems. Current vendor contract language often restricts release of information about bugs and other issues. Contracts may also require vendors to be indemnified against suit. Vendors have evaded suit for HIT systems by including excessive alerts and reminders which are meant to transfer responsibility to the practitioner, making these systems cumbersome.